In this video, we'll be talking about heart blocks, first degree, second degree, and third degree heart block. Before we start talking about it, we need to understand what is PR interval. We have an ECG here, and we need to know where the PR, where it starts from and where it ends from PR interval. Second thing, we need to memorize, guys, the duration of PR interval. The duration is 3 to 5 small squares. So if the PR interval is more than 5 small squares, then that's a problem, and this will mean that there is a prolonged PR interval. We have here first degree heart block. We can see here that in this ECG strip the PR interval is prolonged. The key word here is fixed, meaning all of this PR interval, even though it's prolonged, all of them is fixed, is constant. It does not get longer or shorter or shorter. In the exam they ask you about diagnosis of first degree heart block only from an ECG. Management wise, they don't really focus on that because there is no specific requirement needed. Second degree heart block, there is two types, type 1 and type 2. Let's focus on type 1. Second degree heart block, please note, is commonly asked in the PLAB exam. Second degree heart block type 1 has different names, Mobius type 1 or Wenke back. What is it? In here, PR interval is prolonged, obviously, because this is a heart block diagnosis. Now the keyword here is progressive prolongation as the first keyword here, and then followed by a QRS complex is dropped. So if you focus on this ECG, and if I was to zoom in inside it, you can see here that the PR interval is getting longer and longer, and then you have a P wave, but there is no QRS complex. That's missing. So this is the key thing for Mobius type 1. With Mobius type 1, the PR interval gets longer and longer and longer, and then there is a drop in QRS complex. You can also note down just before the drop, the PR interval is the longest. How about second degree heart block type 2 or Mobius type 2? In here, the key thing here is two things. The PR interval remains constant, just like the first degree heart block. But in here, there is always going to be intermittently a drop in the QRS complex. So if you see this ECG, we have the PR interval is prolonged. Okay, it's prolonged here, but it does not get longer or shorter. It remains constant. And then we have a P wave, but there is no QRS. There is a drop of QRS complex. Management for second degree heart block, we need to know, as they do ask in the exam. Mobius type 1, usually patients are asymptomatic and treatment is not required. Mobius type 2, these patients will require treatment and they need to have permanent pacemaker. Okay, third degree heart block. There is a complete conduction failure in here, so there is no communication between the atria and the ventricle. Because there is no communication, both of them act independently, so you have P wave QRS complexes and they have no association with each other. This is very easily demonstrated on this ECG. You can see here, we can see that there is a QRS complex here, and then we have P wave, then another P wave, and then we have a QRS complex, P wave, QRS, P wave, P wave. I mean, they're just having no association, both of them acting independently. And also note down the bradycardia. So these patients have severe bradycardia and they have high risk of standstill, high risk of ventricular standstill and sudden cardiac death. So if you were to go down here, these are some important points. I just mentioned to you already that these patients have severe bradycardia because there's an absence of AV conduction.